say for our latest podcast session, we're joined by highly esteemed consultant oral and maxillofacial surgeon Mr. Ross Elledge to discuss TMJ disorders in detail. And Mr. Elledge, before the questions, if you'd like to provide some background information regarding your medical career.
Sure. So my name is Ross Elledge. I'm a consultant maxillofacial surgeon. I'm based in Birmingham in the West Midlands. I work privately and within the NHS. I trained in the West Midlands, and essentially my subspecialty interests are skin cancer and TMJ surgery. So I do a lot of jaw joint or TMJ surgery up to and including total joint replacement of the temporomandibular joint.
Excellent. So definitely one of your areas of expertise, TMJ disorders, which will be, I'm sure you'll provide a lot of insightful information for patients who might be struggling with TMJ disorders. So the first question, the most common symptoms of TMJ disorders, how can patients recognise these symptoms?
So most patients come to me complaining of a variety of different things. So one of the things, particularly if they have arthritis within the joint or internal joint derangement, they may be having pain around the joint itself. They might be having difficulty moving the joint, so it might be painful to move, so that then in turn restricts their diet. So they're finding they're having to keep to a softer diet or eat smaller mouthfuls. They may have some physical restriction of mouth opening or a limitation by pain, so they actually can't open their mouth as much as they'd like. And with that, they then sometimes get accompanying headaches, earaches, neck aches, just because of referred pain and pain in the muscles around the joint itself. So those tend to be the main things of pain and loss of function.
Okay, so for patients who are experiencing these symptoms, you would urge them to consult with an oral or maxillofacial surgeon as soon as possible, or should they see how the symptoms develop?
For most patients who have temporomandibular joint problems, most patients will have low-level symptoms. They'll be intermittent and they might self-resolve. There'll be simple things they can do, so they can look online, and there'll be things like little jaw joint exercises, keeping to a softer diet, using some topical ibuprofen gel. And they might start off by seeing their dentist, sometimes their GP, but more often their dentist. And sometimes the dentist can give them quite a lot of advice. So many patients don't need to see me. But certainly if the symptoms are persisting sort of for weeks, and particularly if they've got sort of closed lock and real limitation of opening, and symptoms seem to be getting worse rather than better, then the earlier we start interventional treatment, if that's warranted, then the better.
Fantastic. Thank you, Mr. Elledge. And then leading nicely to question number 2 then. How can patients differentiate between normal jaw sounds and the TMJ-related clicking or locking, as you just mentioned?
So clicking is something that's really common. So a lot of people have clicky joints. And if we had to come up with like a kind of motto of TMJ surgery, I'd probably say one of them is don't treat painless clicky joints. Clicking's normal. About a third of the population will have some degree of a click, and that's often because the cartilage disc within the joint, which acts like a bit of a shock absorber, can get stuck or caught, and as you kind of slide past it to open the jaw, it just clicks back into place, and that's completely that's kind of within the realms of normality. The issues come when either that clicking is painful or creates limitation of movement, or because they have some crunching sounds. So those are kind of bad news. And crunching sounds tend to imply bone on bone. It tends to imply kind of really wear and tear type arthritic changes, and that can be a little more significant.
Oh, that's fascinating. You touched on the kind of the clicking, which is fairly normal. So patients probably who were worried before about that, they'll be reassured by that answer. So that's fantastic. And then question number 3, what are the first-line management strategies for TMJ disorders?
So first-line management, so as I said earlier, most people will get by with what we call conservative management or non-surgical management. So that's often a combination of things. And I usually tell patients just think about it like if you had a knee problem, because it's the same thing, it's a joint. The first thing you do is probably some physiotherapy. for your knee to strengthen the quadriceps muscles and things like that. And the same thing for jaw joints, is if you do some gentle jaw joint exercises, which you can find online, then it'll get your joint moving a bit better, and it might overcome some of the physical restriction and pain. Keeping to a softer diet, so that just during that acute phase, and treating it almost like a sprain. Ice and warm compresses. Some people find one better than the other. Some people find a combination on different occasions better. Topical ibuprofen gel is really good to kind of rub around the area where it's painful, but also supplementing that with maybe over-the-counter painkillers, paracetamol. The other thing is dentists can sometimes make you like a bite-raising appliance, which is like a little device you can wear on your teeth. We're not quite sure how that works, but for a lot of patients it seems to provide some benefit. It probably sort of provides some space and unseats the jaw a little bit, so it's not sort of clenching as much. And just trying to improve things around lifestyle and stress and aerobic exercise, sleep hygiene, all those things are probably going to have an impact on a reduction in clenching and overloading the joint, if that is a tendency for some patients.
Oh, a very insightful answer. Thank you, Mr. Elledge. And then our question number 4 then. When should surgical intervention then be considered?
So basically, for most people, I'd say they need to try conservative management, that non-surgical management, for about 8 to 10 weeks, possibly even longer if they're showing signs of progress. For many patients, that would be the ceiling of treatment. Some people might benefit from kind of formal physiotherapy, and a tiny minority of patients will go on to surgery. So these will really be patients who haven't responded to the exercises and the conservative management. They've got persistent pain, particularly if they've got limitation of movement, and particularly if investigations like scans and x-rays show that they've got a problem within the joint, so either degenerative changes, arthritis, or internal derangement where the joint isn't functioning properly. But it is a relatively small minority of patients who do require surgery, fortunately.
Okay, I suppose it depends. It's a patient by patient, on a patient by patient basis. So, okay, and then question number 5. How is arthroscopy used in the treatment of TMJ disorders?
So arthroscopy is basically putting a camera in the jaw joint in its simplest form. And so the idea behind arthroscopy is that if your joint isn't functioning normally and or there's problems within it, particularly if they've been identified on imaging, then one of the first steps we'll try and do is have a look in the joint. There are not many of us in the country doing arthroscopy, so I seem to be the only person in the West Midlands doing it privately. But essentially, it's a day case general anaesthetic. You're off asleep for it. Takes probably less than 15 minutes for each side. You may need one side or both sides depending on where your symptoms are. The camera is introduced just in front of the ear. It's a really tiny little incision. And then sometimes what we do is we'll add additional ports to that. So basically additional entry points, again just sort of 1 or 2 millimeters in diameter, to try and put instruments into the joint to do things. The idea behind arthroscopy is, number one, we get a lot of diagnostic information, so we can actually see the joint and how it's working, whether there are problems. Number 2, we can take samples, so we can take biopsies and things like that if there's anything that's concerning. Number 3, we wash out the joint, so it actually lavages out any kind of inflammatory mediators, gets the joint moving a bit better. We can also supplement that with sort of steroids to reduce any inflammation, or things like hyaluronic acid that increases the mobility of the joint. And we can also kind of put additional instruments in to do things like coblation, where we remove any areas of inflammation or release muscles to get the disc sitting better in a better position. And there's loads of kind of different things that can be done during an arthroscopy, but the main aim of it is diagnosis and improvement of pain and function. And for that minority of patients that need interventional treatment, most of them will respond to arthroscopy, and only a teeny tiny minority of those patients will then go on to open surgery.
Okay, so it's kind of the first step before open surgery, kind of the leading into that. Okay. Okay, thank you very much, Mr. Elledge. And then our next question is what is the best advice you could offer to those patients who may be uncertain about the next steps in how to manage their TMJ disorders?
I think if you've exhausted all the self-help measures and that are available online, these days there's quite a few different health apps as well that can be quite good and good sources of information. And I think if you've exhausted all those things, then realistically, it's worthwhile at least touching base with your dentist first. And if your dentist is unable to help, or if they've found significant findings on x-rays, then the next person to see is somebody like myself. And ideally you want to see a maxillofacial surgeon who has a subspecialty interest in temporomandibular disorders. So somebody like myself who does arthroscopy, open surgery, Botox injections, whatever's required to get you out of pain and back to function. Because I think it's despite being a relatively common problem, it's actually quite poorly understood by even quite a few people within the specialty. And so it's important to see somebody who's got a focused interest in it relatively early, I think.
Fantastic. And then our final question then, Mr. Elledge. Are there any recent advancements in TMJ replacement surgery?
So a very, very tiny number of patients will need TMJ replacement. There's probably, I would say, less than 200 joint replacements done every year in the United Kingdom. I probably do about 10 to 12 of those, so I tend to average about one a month, more or less. But it's a really niche kind of subspecialty procedure. There are lots of different manufacturers available, so I tend to stick to the same manufacturer that I've stuck to for a long time. And in essence, the technology of them, the joints are bespoke, so they're custom made for the patient. There's a little bit of a manufacturing time to do that, but it's worthwhile. The joint kind of fits the patient themselves. The components of the joint tend to be really high-grade materials, so titanium, aluminium, vanadium alloy, cobalt, chromium, molybdenum and nickel head, which basically has really favourable wear characteristics. The joint is milled, so it's not kind of additively manufactured, it's actually cut out of a block of pure titanium alloy. And the long-term data outcomes for kind of mechanical stability of those joints and persistent absence of pain and improvement in function is just really encouraging for how life-changing that operation can be.
Fantastic, Mr. Ross Elledge, esteemed consultant, oral and maxillofacial surgeon. Thank you for your insightful overview of TMJ disorders. And if anybody listening or watching would like to consult Mr. Elledge or are noticing some of the symptoms mentioned by Mr. Elledge, they can visit his Top Doctors profile and book a consultation with them today. So thank you very much, Mr. Elledge, for your time.
Pleasure.